Many thanks indeed for inviting me to this meeting again. I find it a great pleasure to be in India. I came here a couple of years ago and particularly invited by Dr. Khan and Michel Henry, but also by another French connection of Jacques Bousquet, and I'm very, very happy to be back. My presentation is on the use of intravascular ultrasound, IVUS, and while it can be used for many peripheral interventions as a guidance system to more accurately place the devices, I'm going to tailor this talk for carotids. You can see that the machine itself is very useful in the room. It can be moved around, although you can have them applied to the table itself. And the main part that you should note here is that the size of the intravascular ultrasound catheter is very, very small and can go over, for carotid interventions, a very fine wire, usually the same wire that's used for the cerebral protection device. And the gold chip that you can see there is the ultrasound machine. The image that you get then is in real time, and you pull the IVUS probe down through the lesion under cerebral protection, and you can see here just how narrow or severely diseased and indeed calcified the lesions in the carotid can be. Following treatment, you then will, you'll place your stent, and then you'll pull your intravascular ultrasound catheter down again in order to see the completeness of your treatment. And the IVUS will show you very nicely if your artery is well opened, and you can see the stent struts here nicely open in this particular case. So the clinical use of IVUS is to, first of all, assess the severity of the disease. You can use it to measure the diameter of the carotid artery in order to know what size of balloon and stent to use. And following treatment, you can then check to see how well you've treated your artery or not. And here would be a very typical case, a very tight narrowing, and we can use IVUS, which almost shows you here the histological layers of this artery, because you can see a dark ring in the top circle of the media of the carotid artery and the plaque underneath there. So that's before and then following treatment. But this is not always the case, and very often a stent in the carotid artery, because it's often resisting against severe disease, does not open well. And you can imagine in such circumstances, it's not always seen on the completion angiogram. And yet, if you know about this and you use the IVUS, you can correct it, as in this case, by reballooning it in order to get a perfect circle and a perfect apposition to the vessel wall. And many years ago, I was involved in a study to see how often, in such circumstances of stenting, IVUS would detect whether or not the stent was perfectly deployed in comparison to the completion angiogram. And for carotids, it was found that in 40% of cases where the completion angiogram was entirely normal, the IVUS detected that there was incomplete stent deployment and a problem that you should fix. Following treatment, we were able to improve the cross-sectional area of these arteries in the carotids by 42%, which was more than twice the blood flow, so it was a very important improvement. The second part of intravascular ultrasound that I'd like to talk about is something called virtual histology IVUS. And this is something that uses a color-coded map of the disease in order to identify what kind of a plaque you're treating. And the IVUS probe will detect calcification and it'll color it white. Fibrous plaque is colored in a dark green. Fibrofatty plaque is in a yellow. And the necrotic lipid core is marked in red. And so you can, again, real time, you can get these images in the operating room and decide what kind of a plaque you're treating in the carotid artery. Now, this is the very first case we used the virtual histology IVUS in. And you can see the patient had a very tight stenosis at the origin of the internal carotid artery. And when we used the virtual histology on it, we found that this was a very fibrous plaque. And therefore, as anticipated, when we tried to balloon and reballoon our stent, we found that there was a great deal of resistance because of such fibrous material. And so we began to realize that you could use the virtual histology IVUS to see how the plaque was going to behave at the moment of treatment with a stent. Further to that, we realized that we could also compare any embolic material that we removed from the filter. And so we removed this from one of the cases, and we identified very strong correlation between the type of material that we were retrieving from the filter, in this case, a very, very fibrous part of debris from the carotid, and the virtual histology, which showed a very fibrous plaque. Now, when a carotid plaque grows, it starts with intimal thickening and it builds until eventually it gets this necrotic lipid core, which can rupture. And this necrotic lipid core and rupture is very strongly associated with a stroke. So there are 6 classified pathological stages of plaque progression. And in a study that we did in collaboration with Arizona Heart Institute, and the study was done there, 153 carotid endarterectomy sections were compared with their true histology and compared with the intravascular ultrasound that was done immediately before the carotid plaque was removed at surgery. And you can see just how closely the virtual histology IVUS compares with the different plaque types, but particularly the thin cap fibroatheroma and the calcified thin cap fibroatheroma types, which are termed vulnerable plaque types. They had the strongest correlation, and so we're sure now that the virtual histology IVUS is a very, very good way of identifying very accurately the most vulnerable plaque types, the most likely to cause the patient harm. And calcified nodules, this is just a interest. They're associated with symptoms. Symptomatic patients have these calcified nodules, and you can see here just how beautifully the virtual histology will identify this in comparison to the true histology of a removed section. So we've continued to use the virtual histology not just in the internal carotid, but in this case you can see a patient who's got a tight narrowing in the common carotid artery. And I've accessed this from above with a small surgical exposure, and we've passed the IVUS probe down through the common carotid artery to do the pullback. And you can see on the right-hand side a fibrofatty area with a very tight stenosis, but underneath it there is a lot of red material on this VH IVUS. And where you've got more than 10%, in this 10% rule of red material, that's this necrotic core, it becomes a thin cap fibroatheromatous plaque. And we had a calcified thin cap fibroatheromatous plaque here. It was a vulnerable plaque type, so we used a covered stent in order to treat this and try to do this in a more safe fashion. So in conclusion, I've been very enthusiastic about IVUS, not just in peripheral interventions, but particularly in the carotid artery. And in fact, although it's not done by many people, I use it routinely for all of the carotid stenting cases that we do. Very, very good at assessing the severity of disease, working out the size of the stent to use, and then assessing the completeness of treatment, as well as using this virtual histology IVUS to try to identify how the plaque will behave at the moment of treatment and to try to make it a safer procedure. Thank you very much indeed.